So, as you know, in December, we produced a supplement to our guidelines with two new recommendations, one on partner notification and one on self-testing. And everybody's very, very excited about the self-testing, but the partner notification one hasn't really grabbed people's attention. So I hope I can grab your attention on this. And we think partner notification is really a key way that we can really start to reach people at high risk who aren't accessing testing. And partner notification, or as it's sometimes known, contact tracing, has been around for many, many, many years, and is absolutely the kind of commonplace strategy in STI care. And when I was preparing for this presentation, I just did a quick search on the internet, and most countries have STI recommendations for partner notification. And there's a lot of evidence out there giving the benefits of this. And it's normal practice if somebody comes in with an STI to offer them contacting their partners so that they can also be treated for STIs. Weirdly, WHO doesn't have a recommendation on partner notification or contact tracing for STIs. However, they will be releasing one in June. So they're being spurred on by the HIV department to get their act together to address this issue. Similarly for TB, another infectious disease, it's commonplace in many countries if you have a smear positive TB case to go and offer screening for household contacts. And WHO has had a recommendation on this since 2012. Oops, where am I going? Sorry about this. So we released this recommendation that we should now look, after 30 years in the epidemic of an infectious sexually transmitted infection, that we should also offer assisted partner notification services to increase our ability to diagnose people who would benefit from treatment. And that was really building on some work that we did back in 2012. And many of you in the room, Vincent and Christina, were very much involved in this work on couples testing and counselling, where we recommended couples testing and counselling should be offered to partners throughout a range of services, particularly in antenatal care and particularly for people with HIV. And what's interesting about this recommendation is no one took any notice of it. And here we are 5 years later, and virtually no country routinely offers partner and couples testing, even in antenatal clinics where it would be a very obvious and relatively easy thing to do. There's only one country that really systematically does that, and that's Rwanda. There have been many successful small projects which have shown that it's highly acceptable and highly effective, but and maybe you can give me this answer, but why are we still so reluctant to support partner testing? So the reason we had this recommendation really was to build on the obvious advantages of testing somebody with a sexually transmitted infectious disease, offering testing for their partners, and building on this recommendation and trying to encourage this to happen more routinely in settings. And we were also spurred on by the fact that there were a few studies in Africa particularly that really showed this to be highly acceptable and highly effective in many ways. And some of the architects of these studies in this room, and Peter Cheritich is here, and really we thank him for providing that evidence to support that, and also thank colleagues from West Africa, from Cameroon, who again have led the way in partner notification services. So So partner notification has got many terms, and I think this is again can be slightly confusing for people. It's often called contact tracing. I must emphasize here that it's always must be voluntary, and people who fear that they would risk any adverse events from suggesting a partner be tested, and that partner could then get cross with them, be violent towards them, then that obviously would be something that we wouldn't recommend. And partner notification can be active or passive, and it can be a passive approach where you would offer you go to a clinic, and this actually happens quite routinely in practice, that you go to a clinic, you found out you're positive, and the counsellor in the post-test counselling session will say, well, look, it's a good idea to discuss this with your partner, suggest your partner comes in for counselling and testing. And although that's always been in our post-test counselling guidelines, we know that, number one, it's not often done in a way that encourages people to bring their partners, and partners often don't then go and do that. Other kind of passive ways are to give a leaflet and provide this to the person so that they can bring their partner in. But what we're looking at with assisted partner notification is something that's more active. And really something that the person who tests positive and the person who does the post-test counselling can really together make a way to actively trace partners and really support them coming in for testing and counselling. So there are three major types of assisted partner notification that have been described in the literature. A contract referral, where the person with HIV agrees to be in a contract with the healthcare provider, and they agree that they will tell their partners, and the partner will then hopefully come in for HIV testing themselves. But if the partner doesn't do that, after a specified period of time, then the healthcare worker themselves will contact the partner directly. So it's giving that first opportunity for the partner. If that doesn't work, then the healthcare provider will step in and help them. Provider referral, and this is something that's, has also proven to be very acceptable, is where the provider themselves, at the agreement of the person who tests positive, again, will contact partners, either the regular partner or other partners, again, to offer them direct access to testing services. And then there's a kind of melange of the dual referral, where a trained provider accompanies and provides support to the HIV-positive partner when they disclose their status to their partners, and offers testing together. And all of these have been shown to be highly acceptable, given that caveat that this is always with discussion with the person who tests positive. So why are we here, 30 plus years into the epidemic, and why is this so important? As I said, it's a well-known public health method for TB, for STIs. In fact, it was also absolutely critical to the Ebola epidemic, when people went out and offered contact tracing for contacts of households with Ebola. And WHO produced guidelines on that within about 15 minutes of the epidemic. And these were readily taken up and were absolutely key to the eventual successful outcome of the Ebola. And if you're in a partnership and your partner has HIV, you've got a much, much higher chance of having HIV than the general population. So you really could have that advantage to access testing and get on treatment. And then you will benefit from that treatment yourself. And if you're negative, that also gives you that opportunity to discuss that within a relationship and remain negative within a serodiscordant couple. And we know that couples who can discuss and disclose can support each other to remain in a serodiscordant couple, or to support each other to take treatment together, or support each other over PMTCT interventions. So there are many, many benefits. I'm going to hand over to Brian, who's going to talk about the evidence that we looked at to support this recommendation.
Thank you, Rachel. So I'll proceed with to talk about the evidence. As you know, when WHO develops guidance, we use the grade process. And one of the core pieces of the grade process is to look at the evidence. So with regards to partner notification, there was that review of the literature and the systematic review which was done. There were, after reviewing all the evidence, there were 4 RCTs, and you know that RCTs, we always, that evidence is always taken higher than observational studies. So there were 4 RCTs which directly looked at partner notification, comparing assisted versus passive partner notification. And let me use, I think am I getting old? My sister always says I'm getting old. My wife says I'm old. All right, I think I have to look at this screen here. So, from the systematic review, and particularly from those 4 RCTs, it was clearly shown that assisted partner notification can, 1, increase uptake, which we have agreed is very critical for testing, and then, but it can also result in higher proportions of positive people being diagnosed. And most important, and we had this morning, I think with a colleague who highlighted, it's not just about testing, but it also can contribute to increased linkage to treatment and care among partners of those living with HIV. So definitely there's a very clear benefit that we can get from partner notification. There has been a big issue that's been coming up, the issue of harm, whether partner notification will actually result in increased harm. In the evidence review also, it was shown that actually there is very little evidence, even though there's a general perception that there could be harm. There's very little evidence, both from studies and from programs that have been looked at, to actually show harm. So there are a few cases of harm, but they are not serious issues of harm. But however, even though there isn't as much evidence on harm, it's still important that we consider the potential of harm, and that needs to be discussed with the HIV-positive client. The timing of assisted partner notification has also been shown to be important. So 2 randomized controlled trials, so of those 4, 2 of them, which were done in Malawi, showed that the difference in partner rates between the passive and the assisted becomes more pronounced over time. And so if you look at those 2 graphics, the first one, the first 2 lines, which are closer to each other, are provider and contract referral, which I think Rachel has already talked about. And then the lighter line is passive referral. So you can see over time, the 2 lines are going more apart. So from the first week, you can see that as time goes, there is higher notification in the 2 groups, which are actually the provider and the contract referral, compared to passive referral. And then the other graph basically shows the same, but this is now showing passive versus active. And you see basically the same. Another RCT also showed improved outtake when you actually look at immediate partner notification versus delayed partner notification. That's not presented on this slide. I think Rachel has talked to the benefits, so just to highlight them. So in addition to access to the services, adherence and retention, PMTCT, which I think Rachel has mentioned, and then the prioritization for effective prevention. And this is just an example from the Kenya. I'm half Kenyan, half Zimbabwean, half South African. As you saw, I was in the Kenya team. So this is from Kenya, the experience of LVCT, who have been involved in doing some of the early partner notification work. And this shows an example of assisted partner notification of a young woman who engaged in transactional sex. And I won't go into the detail about the graphic, but basically it shows the networks, and most of the clients and partners were actually traced, and most of them were actually put accessed care and treatment. Some of the challenges that we should expect with partner notification will obviously include the issue of identifying the partners. Because obviously some groups and some people, particularly we talked a lot about the key populations earlier in the morning, may be quite reluctant to name their partners. And also, it depends on the dynamics between the relationships and the partners. So identification of partners could also be a big challenge. Locating and notifying the partners is another issue. And also, we had quite a lot of discussion in the morning about the laws and policies that criminalize, stigmatize, and discriminate, particularly against key populations, but also against people living with HIV. And these could easily present challenges, and they have to be addressed. There are a number of considerations that have taken place when we think about implementing partner notification. I think in the morning, and Rachel talked a lot about confidentiality and ensuring the voluntariness, which are critical. Because partner notification should always be voluntary, and the notification should only be to the partner and nobody else. And also, even particularly, and I think we heard about that in the key populations, the criminal justice law enforcement should never be informed, because we know what will then happen. And also, even workers outside, those who are related in taking care of the patients. So confidentiality and voluntariness is critical and has to be maintained if this would work. And the choice, again, emphasized in the morning and by Rachel. So HIV-positive clients should be given options on partner notification. Rachel has presented the different options. So the clients should have an option to choose which would work best for them. And that may also be different for their different partners, depending on their relationships. And then partner notification is not a one-off thing, because it depends on where the person is. Maybe at the beginning it may be very difficult, but later on it may be easier. So it's important that it's actually offered regularly as the patient's situation or person's situation changes. And then with regards to the methods for contacting for partner notification, again, the preferences will vary. I think we heard about young people, about key populations, about pregnant women. So it would differ by population, it would differ by the age and the partner type, whether it's the direct primary partner or it's the partner of a partner. And there are various methods, and they are listed there. So obviously, face-to-face is one, phone calls, text messages, emails, even video call. And that depends on the people that you're dealing with. Young people may opt for a different method than older people, like myself. But particularly something to highlight with regards to phone calls, and text messaging. So you know if you send a wrong text message to the wrong person, you can actually spread a message very quickly and inform others about the partners and what happened. So those have to be handled quite carefully. Obviously, there are some groups who prefer them, and they do work. They've been shown very clearly in literature that they work, but there's need to be careful about ensuring anonymity and making sure the message still gets to the right person, who is actually the partner. It's very important to also monitor partner notification. So there's need for documentation. We have to put in place monitoring systems and reporting systems, which would then ensure both security and confidentiality of the data, but it also ensures that the right people have access to the data and use it for programming. And those are the different indicators that have to be documented, including the number of persons who are offered assisted partner notification services, those who accept, those who are positive, etc. So in summary then, the HIV obviously is an infectious STI, and there's clear rationale, and Rachel described it quite well, for partner notification to be implemented for both individual but also public health benefit. And partner notification is an approach that actually is very effective, has been shown to have high positivity rate. And you know, at this stage, we need to also increase the yield, of course, in addition to other aspects. And then increasingly, we talked in the morning about men, my gender, and we have a major challenge with them. And it's been shown in a number of studies that we actually can reach men and draw them into testing using partner notification. It has to be voluntary, and particularly in situations where it's criminalized. And we already had presentations on the number of countries where it is criminalized. In terms of the way forward and future activities, there's obviously need to disseminate, and Rachel highlighted that very few countries have introduced actively, and we're actually using partner notification. So there will be need for us who are here, when we go home, to make sure we fully disseminate this guidance to all key people. Advocacy needs to continue so that we can catalyze the different approaches, and so that they become part of our routine HTS system. Because as long as they don't become routine, the benefit that they can give us will not be realized. And then there are some webinars which will be coming up, which WHO is organizing with USAID, and you will be informed, and then I think you can also ask others to connect in. And then there will be need for toolkits and implementation guidance. I think it was discussed in the morning. Just these guidelines we know are not usually enough. So there are usually need for kits. So kits that the implementing partners, WHO and others, will help develop, but there will also be need for implementation guidance in country on how to actually interpret. You had my colleague from Kenya talking in the morning on testing, and I think we have to do the same. And then there needs to be vigilance and monitoring on the implementation, because even though we have shown that there isn't that much harm, we know that there's still a risk, and also particularly there could be a risk for misuse, which we need to track and monitor. So this is just to acknowledge all the colleagues who were involved, including the peer reviewers and the technical working groups and the funding agencies who funded the work. Thank you very much.